Good afternoon, and thank you for joining us today for the webinar, Trauma-Informed Juvenile Justice and Mental Health Systems, Why We Need Them and How to Move Toward Them. This webinar is being offered to states participating in the initiative Improving Diversion Policies and Programs for Justice-Involved Youth with Co-Occurring Mental Health and Substance Abuse Disorders, an Integrated Policy Academy Action Network initiative. This initiative is sponsored by the Substance Abuse and Mental Health Services Administration and the John D. and Catherine T. MacArthur Foundation. And it is an effort to increase the number of youth with co-occurring mental health and substance use disorders diverted out of the juvenile justice system to appropriate community-based behavioral health services and to reduce the inappropriate and unnecessary contact of these youth with the juvenile justice system. Before we begin today's presentation, we would like to review a few housekeeping items. First, this webinar is scheduled for 90 minutes. We anticipate questions and have built approximately 30 minutes into this schedule for responding to questions raised by the attendees. We are using GoToWebinar technology for this presentation. So if you have a question at any time, please use the question or chat function on the right-hand side of your screen. We will do our best to answer all of your questions before the webinar is over. Finally, we will be recording this webinar and will make the recording and slides available on the Policy Academy Action Network resource webpage. The link to the resource webpage was provided to the core team members from each state following the Policy Academy Action Network meeting in June. If you have any questions, please don't hesitate to contact the National Center for Mental Health and Juvenile Justice or me, Carly Cater, at kkeator@prainc.com. Youth involved in the juvenile justice system are likely to have experienced traumatic events that over time can lead to serious behavioral and emotional problems such as post-traumatic stress disorder, complicated grief, reactive aggression, risk-taking, substance use, and isolation or involvement with peers who are involved in delinquency. The presentation today will provide an overview of evidence-based and efficient methods of screening and assessment to identify youth in need of trauma-informed services or trauma-specific treatment in juvenile diversion programs and describe evidence-based or evidence-informed trauma-specific treatments to which youth in diversion can be referred in order to support their safe and productive involvement in their families, schools, and communities. The Sampson MacArthur Foundation Policy Academy Action Network Initiative presents a unique opportunity for participating states to develop trauma-informed policies and programs. Today's presenters are Julian Ford and Monique Moreau. Julian Ford will present first, and he received his PhD in clinical psychology from the State University of New York at Stony Brook. He is a professor of psychiatry at the University of Connecticut School of Medicine and director of the University of Connecticut Health Center Child Trauma Clinic. He has developed the Target Trauma Affect Regulation Guide for Education and Therapy Treatment Model for adult, adolescent, and child traumatic stress disorders and conducts research on psychotherapy and family therapy, health services utilization, psychometric screening and assessment, and psychiatric epidemiology. Dr. Ford has prepared expert white papers on trauma and mental health for the National Child Traumatic Stress Network, the National Center of Juvenile and Family Court Judges, the National Center for Mental Health and Juvenile Justice, and the Child Health and Development Institute. Our second presenter today is Monique Moreau, who holds a doctorate degree in child clinical psychology from The Ohio State University. She currently serves as a psychologist for the state of Nebraska Department of Health and Human Services, Division of Developmental Disabilities. She also currently serves as Juvenile Justice Consultant for the National Child Traumatic Stress Network and Co-Project Director for the Cincinnati Children's Hospital Child Trauma Grant, which focuses on developing and disseminating training and trauma-focused interventions for youth in the juvenile justice system. In 2010, Dr. Moreau was appointed to the National Child Traumatic Stress Network's National Steering Committee and has served several years on the Affiliate Advisory Board and is co-chair of the Juvenile Justice Trauma Treatment Training Committee for the National Child Traumatic Stress Network. So we are ready to begin. Dr. Ford?
Thank you, Carly, and welcome everyone. And I want to thank the National Center for Mental Health and Juvenile Justice and Dr. Kokoza and Carly and their team for the opportunity to talk with all of you about what I think is a very important topic, and I hope you'll find that this is practical and useful information. So we know that there are many, many children and adolescents in the juvenile justice system every year, as many as 2 million in the United States alone. And we also know that a substantial proportion of them, a minority, but a substantial proportion are girls, and that's increasing over time. We also know from several studies that somewhere between 60 to 90 or higher percent of those youths have experienced psychological trauma, often multiple types of trauma. And for girls, that often includes, unfortunately, sexual abuse. For both boys and girls, they are highly likely to have experienced physical assault. And many have experienced a wide range of other kinds of traumatic stressors, including domestic violence, community violence, traumatic losses. So these are kids who have been through a lot. They often develop post-traumatic stress disorder, although that's just the tip of the iceberg in terms of the kinds of problems that trauma can lead kids to experience in any domain, especially those who become involved in the legal system. And some estimates are as high as 1 in 4, or even 1 in 3 in other countries of kids in the juvenile justice system who will develop PTSD. So the first step in helping these kids is really to identify them and find those who are going to need help. If as many as 90+% have experienced trauma, then the question really is more what types, how much, and what effect has psychological trauma had on these kids. One way to approach that, as you can see on this slide, is a kind of a general screening for many, many different types of traumatic exposure. And the Traumatic Event Screening Instrument, the TESI, which a group at Dartmouth and the National Center for PTSD that I've worked with has developed, provides kids with a way of telling us, or parents and caregivers a way of telling us what kinds of specific, very behaviorally specific trauma events have occurred to a boy or a girl. And we include in that, in the TESI, not only violence and victimization, as important as that is, but also accidental trauma, the kinds of traumatic exposures that can happen with kids who can be risk takers and sometimes can be fairly oblivious to their safety, which is part of the marching orders for all adolescents, but can be particularly true for those who are struggling with impulsivity, reactivity, and the kinds of difficulties that can lead to legal problems. So the TESI surveys 18 different types of potentially traumatic events. It asks questions that allow you to determine if this was both physically life-threatening or a sexual violation, or very, very serious injury to the child or to someone else, or if it was and also if it was disturbing to them, using the DSM-4 criterion A, which includes the subjective response. And that may no longer be required in DSM-5, but it's still important to know. Although one side point, very often kids who experience traumatic events don't say that they were scared, don't say that they felt helpless, don't say that they felt horrified, but they may say that they felt nothing at all, that they spaced out, that it just didn't bother them at all, and those potentially can be manifestations of a very strong subjective response. It's not just obvious fear, helplessness, or horror, and many kids are reluctant to acknowledge that even when they did feel it. The TESI can be done in as few as 10 minutes. There's a Spanish translation. We have good experience in a number of areas, but in all of the Connecticut juvenile justice pre-adjudication programs, including probation and detention, it's being used and providing a lot of very helpful guidance to the staff and the clinicians working with those kids. I actually can provide copies of that at no charge, and this can be obtained by emailing Amy Stomsky at the email address on the screen. Another way to look at trauma history is to focus specifically on victimization. And David Finkelhor and his group at the University of New Hampshire have developed a juvenile victimization questionnaire, and that has a screening version, a briefer version of that. They have done a very large national epidemiological study of children and victimization. But this is a briefer screen that can be used for the youth by self-report or, again, by caregiver or parent report. It takes about 10 minutes. It asks about 34 different types of very specific victimization that can include due to crime, abuse, assault. It can include by peers or siblings, as well as witnessing violence. And that's going to actually be used in a recently funded project that we're doing in Connecticut with all of the court coordinators, social workers working in each juvenile court, where we're going to actually be looking at whether providing them access with this screen and the information from it helps them to make more nuanced recommendations and to actually better identify kids who have experienced traumatic victimization and may need help. That can be obtained from the website that's on the screen through the University of New Hampshire. Another way to screen for trauma history and exposure is to go back to the Adverse Childhood Experiences study, the ACEs. And there's a screening instrument that's been developed for that specifically can be used either by kids, again, or more commonly by parents or caregivers. And it asks 10 very clear, simple questions about very complex kinds of adversity that include abuse, neglect, but also ones that aren't always asked about in other more trauma-focused or victimization-focused assessments, such as parental impairment due to substance abuse or due to mental health problems. And that's been used as a part of the Centers for Disease Control behavioral risk factor surveillance on a national basis. And it can be obtained and more information about it from the CDC at the website on the screen. You might also, of course, want to know not just what's happened to the boy or the girl, but what's been the effect. And one way to ask directly is about PTSD symptoms. And the UCLA PTSD Reaction Index is a very nice, efficient, brief measure. It actually has 22 questions, and it asks about all 17 of the PTSD symptoms in the DSM-IV. It also asks about a few additional symptoms that may be relevant, including dissociation. And it can be done either by self-report or, again, by a report by a parent, a caregiver, or a clinician. And we found that, again, to be very useful in all of the pre-adjudication programs in the Connecticut juvenile justice system. And that can be obtained through the National Child Traumatic Stress Network at the website that I've given you on this slide. The MACI-2 is so widely used in juvenile justice systems that, of course, it needs to always be considered as a source of potential trauma screening. It has a traumatic experiences subscale, but several studies, including some more recently by Dr. Grisso, the measure developer, as well as by my group and Patricia Carrick's group in Utah, have found that it tends to under-identify kids with trauma exposure and potentially those in need of help with traumatic stress symptoms. So it's also very useful to consider, if you're using the MACI or if you have those data, to look at the scores on the anger subscale, the depression and anxiety subscales, because those have been found to be quite relevant, and they don't specifically relate to trauma exposure. But kids who score high on those subscales are likely to be at risk for having had trauma exposure and other PTSD symptoms. And these are kids who often will not acknowledge some of the briefer subset of PTSD symptoms that is included on the MACI. The suicide risk and substance abuse subscales also are crucial, not just for trauma exposure, but for some of the more severe effects of post-traumatic stress. And we've found that it's very, very useful in combination with both the TESI trauma screen and the UCLA PTSD symptom screen. And that can be obtained through the National Youth Screening Program that Dr. Grisso develops at that website. Another screener that is more broad-based is the GAIN, the Global Assessment of Individual Needs, and that substance scale. That includes traumatic stress symptoms. It's a very nice, brief measure, so you can assess both the often very serious substance use problems as well as traumatic stress symptoms in one single instrument that's very efficient. It's not clear, however, how effective it is in actually detecting clinically significant post-traumatic stress. It may very well be, but that hasn't been documented. And it would be optimal, we found, follow any positive cases there with more specific trauma history and PTSD symptom screening, such as the TESI and the UCLA PTSD Reaction Index. And that can be obtained through the GAIN Coordinating Center at the website. One other area that we found is very helpful in the juvenile justice system in Connecticut and actually in several other states is not trauma-specific, but is certainly one of the results of exposure to traumatic stress that often is of great concern to staff in programs, to probation officers, to prosecutors and public defenders, and to courts and judges. And that's the kind of dysregulation that happens when kids go into survival mode after experiencing traumatic stressors. And there's a very nice brief measure called the Abbreviated Dysregulation Inventory that's been developed by Dr. Ada Message at the University of Pittsburgh, and I've given her contact information on the slide. And in 30 items, it asks the youth, or you can also have this rated by a parent or a caregiver. It takes about 5 to 7 minutes. It's been translated into Spanish as well. So it's an excellent way to zero right in on some of the important problems with behavioral dysregulation, impulsivity, reactivity to stressors, cognitive dysregulation, difficulties in thinking clearly, organizing thinking and problem solving, and just emotional dysregulation. The challenges that we face in trauma screening, I've just listed 4 of them, but just to quickly step back, it's great to have these measures. None of them are perfect. All of them depend upon the accuracy and the willingness to acknowledge information that is often very limited on the part of kids who are involved in juvenile justice for a variety of reasons, legal and psychological and social. So very often kids underreport, and we always have to assume that just because a boy or a girl says no to everything, that doesn't rule out a trauma history or traumatic stress difficulties. It just means that at this point, under these circumstances, they're not willing to acknowledge them. They may be having little or no problem. They may have actually had a very limited exposure to trauma, but that is unfortunately not something that can be assumed. What we do know is that when they are willing to acknowledge trauma history and traumatic stress or dysregulation symptoms, that they are clearly saying that there's a need for help. And those are the kids who can at least begin to particularly provide additional help to. There's also more than just PTSD, as I've mentioned. PTSD is very important, but the kind of anxiety, hyperarousal, unwanted memories, and emotional numbing that are part of PTSD are only the beginning of how trauma affects kids. We'll talk more about that in just a moment. It's also very crucial not to do any of these screens without making sure that the providers and the staff who use the findings know how to interpret them. The most common question is, what does that score mean? And so it's very important to be knowledgeable and follow careful guidelines based upon the evidence base for how to interpret the findings so that they're neither underinterpreted nor overinterpreted. And always there have to be services. And of course, we can never screen and then not do anything about it. That's the universal precaution. One of the things that comes next is a trauma assessment. When that's possible, and this requires more professional training. An example would be the clinician-administered PTSD scale for children and adolescents, the CAPS-CA. Another example would be the structured interviews such as the CASADS, or the DISC, both of which have modules for PTSD, which can be useful. And a group has recently developed a structured interview, and we're actually doing a field trial that's being co-led at my site and in Boston at the Justice Resource Institute to test out a proposed new diagnosis for traumatically exposed children and youth called developmental trauma disorder. And I'd be glad to talk more about that if there are any questions about that. The challenges in trauma assessment that I want to highlight are, even when you have an excellent structured interview and you're able to really dig a little bit deeper than you can with a questionnaire and talk about how that boy or girl is actually dealing with life rather than just asking them, do you have this symptom, yes or no, and come up with a clearer picture of how they may be troubled by traumatic stress symptoms, even though they may not realize it. They may think that they're just angry all the time. They may just think that nobody understands how they feel or nobody really cares about what's happening to them in their life. And they may be partially right in having experienced situations and interactions where there was less concern with their well-being than with the problems that their behavior is causing. But it's also the case that most kids don't recognize when they are avoiding reminders of past traumatic experiences, and most kids are not aware of how vigilant they are. Now, most adolescents are relatively hypervigilant, but not in a clinically symptomatic way. They're on guard because their brains are developing in ways that would lead them to need to verify before they actually trust. But the avoidance and hypervigilance in PTSD or traumatic stress problems is really more of a survival reaction. It's really not just to test adults and make sure that you can get your way or you get things to work out the way that you want or that they're going to take care of you in the way that you hope. It's much more, is this person going to hurt me and how? And that becomes so second nature that many kids don't even realize that they're doing it. For us as assessors, then, we have to look a little bit beneath what they say and look at their behavior to see the ways in which they may actually be protecting themselves using aggression, using school dropout and truancy, using defiance and appearing to be very oppositional and defiant. Even conduct problems may be actually an attempt to use the best defense, which is a good offense. It's also true, again, that it's not just PTSD. It's all kinds of dysregulation. And as with screening, it's essential that whomever uses this information knows how to use it properly and has good evidence-based guidelines. So we're really talking about a special group of kids who often struggle with problems that I've mentioned: aggression, impulsivity, risk-taking, and under the surface, often not admitted, but often relatively obvious, a deep sense of disillusionment, alienation, and dysphoria or depression. And we know that these problems are highly associated with exposure to traumatic violence, also to traumatic loss. And we also know that very often kids in the juvenile justice system look like they're intentionally aggressing or harming others or breaking rules, but in fact, very commonly, their aggression or their rule breaking or their defiance and oppositionality is entirely reactive, and it's an attempt to cope with a kind of biological stress reactivity that they don't even recognize themselves. They know they have to defend themselves and protect those who they care about, but they don't realize the extent to which that is actually driven biologically. And amazingly enough, that's actually an avenue that we can use to help them. It's not actually something that will lock them into traumatic stress problems. So let me just pause for a moment. Are there questions? It looks like I think I see one on the chat board. Oh, that's a mute question. Okay, did anybody have a content question so far? Or are we all on the same page?
Julian, we do actually have a question. If you could go back to the slide on trauma screening where there's the bullet on challenges in trauma screening.
Yes.
Back a few. And on the last bullet where it says must be followed by appropriate services, one of the attendees raised the question of some think it's appropriate to screen to be able to assess the need in spite of knowing that there are not sufficient services to meet the need. Can you respond to that issue, that is whether or not to screen if you know that there is a capacity or not a capacity to meet the need?
Well, that is a real conundrum. The one reason I can think of why that would be a good idea would be if that could lead to a heightened awareness on the part of people in the system or funders to actually develop services. So if screening could be a route to actually providing more or better services for kids in the system, then I think that certainly is helpful. It's also the case that if there are adults in the system who may not be service providers, but for example, probation officers who have received some reasonable and some even excellent training of the type that Dr. Merrow is going to talk about a little bit later, there don't have to necessarily be formal clinical services in place. A trauma-informed program, facility, or probation office can be just as important as having clinical services for treating PTSD. And that can be, if that can be accessed and those individuals, those providers can identify who needs, which of the kids may most need this kind of trauma-informed treatment planning, services planning, case planning, support, then that's actually a perfectly good rationale without having to have formal treatment services. So I appreciate the question, and I hope that gives you some ideas. We don't want to drop kids into a black hole where they tell us something very, very personal and disturbing to them, and then we don't do anything. The only question is, what is the best thing to do? And sometimes that's trauma-informed juvenile justice services and not necessarily clinical or treatment services. Okay, so let me go on. I'll jump back ahead to, well, what do we do with these kids who are the survivors? And they themselves often don't even know the full extent to which they are responding to a kind of a biological imperative to protect themselves. Well, one way to think about that is we can help them with emotion or affect dysregulation. So what do I mean by that? Well, in down-to-earth terms, it's way more complicated than this, but all that I can remember are three basic things. When you can't stop and think, which of course is endemic to adolescents, but is particularly true for trauma survivors. When you can't calm down and soothe yourself, when you get very upset. Again, something that's often difficult for adolescents, but even more so for kids who've experienced traumatic victimization or other traumatic stressors. And when you can't experience other people as sources of calm, hope, companionship, and partnering. When you really tend to think of other people as primarily problems or potential victimizers, which is unfortunately not all that uncommon for kids in the juvenile justice system. Not because there aren't adults and other people who have cared for them and who have been trustworthy, but because they've encountered some who are not. And as a result, they clearly feel, without even realizing it very often, that they have to verify before they can ever trust. So how does this show up? Well, it can show up in the form of memories, not just of trauma, but memories of periods of life that are very fragmented and chaotic or incomplete. A difficulty in doing what we call mentalizing, that is, being able to step back and just ask yourself, why do I think that? And how's the way that I'm thinking different from how this other person is thinking, and how can we actually establish a kind of a mutual agreement about how to think about this particular challenge or question or problem? Of course, it manifests in hypervigilance and hyperarousal. It can also take the form of rumination and just profound pessimism. It can take the form of being actually phobic of feeling anything, of any emotion at all. It can take the form of distrust, or, on the other side, of over-reliance on relationships, which can lead to either isolation or dependency. And, of course, it can take the form of aggression as a way of actually defending against potential future harm. And we know, by the way, that one of the things that kids, we know several things, I should say, that are different about the brains of adults, and we're just beginning to verify this with children and adolescents as well, when they're experiencing this kind of post-traumatic affect dysregulation. The middle one, by the way, the dysfunction, the hyperactivity of the amygdala, that's the classic PTSD hyperarousal alarm reaction. And the reduced prefrontal inhibition, that just basically means that the thinking part of the brain just can't turn down the alarm. And we'll show you how we actually teach adolescents about that, as well as their caregivers. We also know, going up to the top bullet, that actually post-traumatic affect dysregulation actually involves not only these kinds of classical alarm and anxiety and anger reactions, but also a difficulty in what's called the default mode network. And that is a network of areas in the brain that has been relatively recently identified that specifically enables all of us to be able to step back, and just reflect on what has happened in our lives and sort out situations and problems. And that's absolutely crucial, but it's largely impaired in individuals with serious post-traumatic affect dysregulation. So not only are they experiencing a great deal of reactivity, but they're also experiencing difficulty in sorting out that reactivity on a very biological brain basis. And they're also, going down to the third bullet, very likely to experience difficulty in emotion regulation. Just simply recognizing emotions and emotion states tends to be impaired in post-traumatic stress. So that's a pretty challenging combination. As a result, these are kids who are prone to emotional flooding, but they also may be alexithymic and just not be able to recognize or name any emotions. They may express feelings in terms of body states and be somatically impaired. They're obviously likely to be disinhibited and impulsive. They are prone to be defensive and reactively aggressive. And unfortunately, with all of that working against you, it's hard not to start to think that maybe you're the problem, even though kids will tend to point the finger of blame outside. Underneath, we know that very often they consider themselves the problem, and it can even be as serious as self-loathing and self-harm. And it can lead ultimately, although only in a small subset of cases, to kids who literally lose track of themselves and have to kind of shift into very different ego states so that they are literally not the same person from moment to moment. That is rare, and it's not just dissociative identity disorder. It can take the form of many types of dissociation where the individual just simply is not able to recognize themselves and the situation in the same way from moment to moment because they are so overloaded with the information and the threat involved in trauma. So what do? Well, we got to help them to be able to stop and think, let go of grudges and resentments, set and stick with goals, decide who to trust, but at least be willing and able to take a risk on trusting, decide who really is trustworthy, and be able to use the skills that we're teaching them, such as anger management skills, at the most difficult time of all, such as when they're angry. So what we're really talking about here is a vicious cycle where if you start on the left-hand side, we've got all these forms of complex trauma. They lead to a brain that is in alarm state, that's not reflective, that's not really attuned to emotions in the same way that we would ordinarily hope, even though that's a challenge for all adolescents, which in turn leads the boy or the girl to be on alert and on guard and not feel safe because they literally can't think in a way that gives them the ability to feel safe. That then leads them to feel very emotionally dysregulated, either too much, too little, or just too awful set of emotions. And that in turn can lead to the kind of aggression and reactivity that then makes them at risk for yet more exposure to trauma. Here's a virtual quote that pretty much encapsulates the dilemma. I've got all the skills I need, but when I'm angry, I can't stop and think, and so I fight back. I don't use the skills. I can't even remember them because no one's going to make me a victim ever again. It's a tragic dilemma, but very familiar. So what do? Well, we can't begin to talk about all of the different interventions for PTSD that have an evidence base for children and adolescents, and I'm going to focus on adolescents. But as you can see from this slide, there really is quite a remarkable array of them, and I won't go into all of them, but that's just for your reference. You can see that there are many interventions that provide a variety of approaches to helping kids. And the question is, what do they all have in common? Well, they're all very different, but each one of these, in one way or another, increases the kids' self-efficacy in coping with both memories of trauma and the hypervigilance that they feel. They also, each of them in one way or another, increases the boy or the girl's safety by reducing their reactive aggression, or excuse me, avoidance and dissociation, and anger and aggression. And they all are intended to provide adult guidance and role modeling. in ways to actually be mindful and to manage anxiety, anger, and impulsive and addictive behavior. And the way they do this, well, before I go to that, and they don't address the full range, or they're just beginning, I should say, to address the full range of dysregulation. And that's why we may need an additional diagnosis, not to add more diagnoses, but so that kids who otherwise get diagnosed with PTSD, oppositional defiant disorder, bipolar disorder, many different anxiety disorders, a range of ADHD very often, as well as affective disorders, major depression as well as bipolar. Those kids who get a laundry list of diagnoses and who are trauma survivors might actually be better treated rather than providing treatments for all of those different disorders, which is almost impossible. They might be better treated by focusing on the affect dysregulation that is the result of post-traumatic stress. And we need to be able to explain to them and to adults exactly why stress reactions are creating these difficulties with managing their behavior and being drawn towards delinquency and dangerous behavior. And we need to give them skills so that they actually can do something to stop and think and make good choices, rather than just knowing that they should do something but not knowing what. So here, in brief, I will come back to developmental trauma disorder if people in the audience would like to talk about that a little bit later. This is just a summary of the types of dysregulation that we view as involved in this very complicated response, but very familiar response of survivorship in the aftermath of trauma. And let me just give you, in a couple of minutes before I close, an example of how it's possible to explain, even to a teenager who doesn't really want to listen to any of us adults, what's going on in their brain in a way that actually may motivate them to use some skills that they already have in a way that they didn't realize. So what we do in the particular model that I'm working with, the target model, is we just explain that everybody has an alarm system in their brain. It's designed to keep you alert, but when it gets set on emergency mode, it's got to get reset. Otherwise, you will stay on emergency mode, and that's what can lead to the extreme reactions. And when you experience the survival threat, it's natural for this alarm system to get stuck on in emergency mode. That's not abnormal. There's nothing crazy about it. But the key is, how do you turn it back down once it gets stuck on emergency mode? And so we show kids a picture of the brain, and we show them where the alarm is, we show them where the memory center is, and we show them where the thinking center is, just to help them have a visual way of thinking about this. Adults find this helpful too. And we show them what happens when the brain and body are working together. The alarm goes off when there's a stressor or some potential danger. And then the memory center comes up with some information from past experience to help you figure out what's going on. And then the thinking center comes up with an understanding, an idea, a way of figuring this all out, and that turns down the alarm. But what happens when the brain's under extreme stress, like trauma? Well, then the alarm goes off, but it's so powerful that it leads to memories that are primarily of terrible things that have happened. And this might be an alarm situation that's a minor stressor, but the memories that get pulled up are of terrible things from the past. That, in turn, leads the thinking center to draw conclusions such as, this is as terrible as I think it is, I've got to do whatever I've got to do. And so now we've got an alarm that actually is getting turned on stronger and stronger rather than getting turned off. We then show kids and adults that it's possible to use the thinking center to reset the alarm in the brain using 7 apparently simple but actually relatively complicated steps, but ones that are actually taught in every single treatment and actually in most approaches to rehabilitation as well. They're just not fleshed out in quite the same way that a trauma perspective can provide. And just to give you one quick illustration, one of those steps, the very first one, involves something as simple as just slowing down and sweeping the mind clear. and then orienting yourself to something that is safe and that you can focus on, that's important to you right at this moment, and then doing a quick self-check of your stress and your personal control level. It's remarkable how kids will actually take this and make it their own system. And we teach them the difference between reactive and what we call main, or really helpful goals, thoughts, and emotions. And we found that in doing this with kids in detention, that actually it was associated with a reduction in dangerous incidents, a reduction in seclusion over a 2-week stay time, and recidivism actually was decreased during the period when this is being taught. We also, Dr. Merrill will tell you a little bit more about a larger study that was done under her leadership in Ohio, where they found some very similar results in terms of reduction in dangerous incidents, use of seclusion, and disciplinary responses, but also some improvements in depression, in hope and self-efficacy, and even in satisfaction with services. So what we've got to do then is we've got to think, how could we take approaches like this? And as I showed you on this earlier slide, there are a number of them available. How can we take those approaches and infuse them in juvenile justice systems? That's going to take a lot of talk, a lot of planning. We need trainings, and that's where Dr. Merrill is going to take us in just a moment. We need ongoing support and consultation for the people who are trained so that they can actually apply a trauma-informed perspective, use the screening instruments, use these approaches to education and even to treatment in ways that then will be done with fidelity, with competence, and that can be adapted for girls as well as boys, for different cultures and languages, and also for kids of different ages. And essentially what we're talking about really is shifting from a punitive to a restorative and rehabilitative justice model. And there's a lot of support for that, even from some of the old hands in juvenile justice systems. Many of those folks really do want to see kids do better. They don't really want to punish them, but their hands have been tied in many cases. And it's also a way to help people to recognize that we who work with kids and every adult who works with kids in the justice system are affected by the trauma they've been through. And there's something that our alarms get turned on in our brains too. And we need to make sure that we know how to work with kids and how to take care of ourselves in a way that is truly trauma-informed. And with that, I'll turn it over to Dr. Merrill.
Well, thank you, Julian. That's a nice introduction to the sections that I'm going to be talking about today. Dr. Ford talked a little bit about interventions that have some evidence base, and on his list included the one that's up on the screen now, which is trauma and grief components therapy for adolescents. Myself and some individuals from the University of Cincinnati Children's Hospitals, Dr. Olafson, Dr. Boat, and myself, worked to adapt a curriculum that was developed by Lane, Saltzman, and Pynus for use in juvenile justice settings. So as Dr. Ford talked, there are many components of a lot of these interventions that are very similar because they're designed to address the symptom pictures that kids present that have, generally speaking, complex trauma histories. Okay, I'm moving. Okay. This group treatment really addresses the emotional and behavioral dysregulation and includes very specific trauma and grief processing components with some exposure therapy that happens through the creation of a trauma narrative. So this model actually includes, in addition to psychoeducation, which is really Module 1, and management of trauma reminders and some coping skills, it also includes helping the youth work through a trauma narrative in a group format. In addition to dealing with traumatic experiences, we also talk about traumatic losses or traumatic deaths, and that's included in our Module 3. And then the final module of this curriculum focuses on resuming developmental progression, because a big issue with kids who experience complex trauma is they become what I call 16-year-old, 5-year-olds. They are physically growing, But in terms of other areas, in terms of their coping responses and other developmental domains like social expectations and future planning, that a lot of times those things become arrested or fail to develop. So we work with them on not having to focus so much in the moment on consistently being safe and focusing a little bit more on future planning and resuming developmental progression. So that's just another model that's out there that's potentially useful for working with kids who've experienced trauma. It has been used both in juvenile justice settings, in intensive outpatient programs. We used it in alternative school programs, and the original developers used it in a high school program that had experienced significant violence. So it is a program that can be used in many settings. Okay. As Dr. Ford mentioned, which I think is really important to think about, is you may or may not be able to implement an entire trauma-focused intervention in the setting in which you are located or in the program in which you are located. And I guess in my own opinion, in addition to that, is unless you are doing a really good job of making sure that everybody in the program is on the same page and has a good understanding of trauma, it's often difficult to really be able to surround the youth by the amount of support that they need and understanding to make all of the progress that they need to. So one of the curriculum that might be available for you that was developed through the National Childhood Traumatic Stress Network by myself and Dr. Joe Benamati and our Juvenile Justice Treatment Committee is the Think Trauma Toolkit. This is a modularized, skills-based, interactive, trauma-focused training curriculum that was designed for staff who work directly with youth and was designed, as I said, for people in the juvenile justice setting. But it has also been used in multiple other settings, including in diversion programs, in communities, in alternative programs, and with others that work with at-risk youth. As a kind of a brief, this is our series overview. It talks about the modules that are available for this curriculum. In Module 1, we talk about the relationship between trauma and delinquency, and we reiterate some of the same things that Dr. Ford talked about in terms of how it can relate to aggression and dysregulation and some of the behaviors that you often see in youth like this. In Module 2, we focus very specifically on trauma's impact on development. Module 3 is focused on coping strategies and very specifically on what we call or term survival coping strategies, which is a borrowed term from work by others. In Module 4, we really focus on vicarious trauma or organizational stress and self-care. And we thought that was vital because a lot of times it's very difficult to work with kids who have experienced complex trauma. They're difficult to understand. Their behaviors seem to come out of the blue. So it could place a lot of stress on the staff that work with them. So helping them to really look at themselves and what their needs are and to look at the organization and how working with these youth at times can stress the organization becomes really important in terms of developing an overall treatment model. So let's take a look inside the curriculum. This is Module 1, and I should go back, sorry. And as I've noted, this module is really focused on helping people to come to a clear definition of traumatic stress and how it differs from everyday stress. It also explains traumatic reactions and trauma and loss reminders and their potential role in influencing the behaviors of youth that we come in contact with. It ends with a discussion of resiliency, which I think is extremely important because in order to be able to overcome or recover, it's going to be important to really focus on resiliency factors as a part of that. So why Module 1, or what are we doing with Module 1? It's designed with lots of media and activities purposely selected to help those working directly with youth to better understand the way traumatic stress can be expressed emotionally, behaviorally, cognitively in the youth they work with. And one of the things that we did when we built these modules was to really emphasize discovering. So there is some didactic portions to all of the modules, but our goal is for the participants to really understand via their own uncovering of what traumatic stress is and how it can impact a young person's life. Thus, we do use a lot of media and activities. The other thing that we try to accomplish with this curriculum is it's designed to ensure that the audience understands right off the bat that the training is designed to help better understand youth like the youth they work with. This is communicated through the use of our clips, including clips from the movie Freedom Riders, and then there's about 6 case vignettes that we use that are based upon youth that we have worked with, but really elucidate some of the issues that kids with trauma may experience. We found this to be really important to use this because often when you go to do a presentation on something like traumatic stress and you're beginning to talk about the behaviors and you're beginning to talk about the symptom picture, you will find that individuals may say, well, you know, that's not the types of kids we work with, that this is an opportunity to establish that the kids that you're talking about in this curriculum are the same youth that they may be working with in the community. It's kind of a credibility or validity check when you're able to present a case vignette. So during the presentation, each participant sets a tables of 6 and is assigned a youth to work with who's presented to them as a puzzle. So as you'll see there in that slide, there's a puzzle of a young person. These puzzles contain the same information as the vignettes that the facilitators receive. The picture is displayed on the front of the puzzle, and on the back are the youth life stories told from the perspective of 6 different individuals, each representing a different piece of the youth's life. Usually these include like the staff member that works on the unit, so maybe a security staff person, a social worker, the parent, the youth themselves, a teacher, and possibly a probation officer or healthcare professional. Each of the 6 participants is asked to take one piece of the puzzle and use that information in discussion with the other 5 participants to answer the activity questions. The goal is to help participants understand that no one really has the complete story, not even the youth themselves. They will need to work together to better understand how the youth presents so challenging behaviors and painful symptoms can be resolved. So in this particular section or activity, they're asked to use their information to answer, you know, what were the traumatic experiences or losses that this youth had? What were some of their trauma reactions? And I also asked them to look for their coping strategies, which, as we noted before, I call survival coping strategies. And, you know, what might be some of the potential trauma reminders? And this is not that all of that information about reminders is in the vignette, but they are asked to consider, based on what's presented, what might be trauma reminders. So we've done some education about that, and now they're to use that to answer the question. The same format is used in modules 2 and 3 in terms of using this young person. There they are going to be asked to look at the survival coping strategies. They're going to be asked to look at developmental impact, and in module 3 look at the survival coping strategies and alternatives. So module 2 of the toolkit explains the impact of trauma on multiple developmental domains: cognitive, biological, behavioral, social, and emotional. And it really focuses on how developmental delays and missed developmental skills have the potential to disrupt the acquisition of both affective and behavioral regulation, as well as attachment to others, and consequently the development of a secure sense of self. So that helps the child to be able to function safely as an adolescent and transition into adulthood. So in this module, we have some discussion briefly of young children and middle school age children, and then focus most of the module on what are the key developmental tasks of adolescents, and how does trauma or complex trauma interfere with youth being able to achieve those developmental tasks. So similar to the first module, you'll again interact with the puzzle on the table. And in this module, one of the things that we want to focus on is the ways in which trauma or traumatic experiences really changes the youth's view of the world, themselves, and others. And so we find this to be really important in terms of people working with young people who've experienced traumatic stress, because often how they see you is really not based upon who you are and how you present at the moment, but is triggered as in many ways, like Dr. Ford talked about, by their traumatic experiences. And so they have negative expectations often of people they meet or new situations. And so we try and help the participants understand that thinking pattern, because it can often interfere with your ability to do other forms of treatment. These kids can often be offsetting. If you think about when you're working with them, you may not be the most likable youth, because they present often as kind of very cold or distant, and really that's an attempt to protect themselves. So the goal here is to have them look at how the youth sees themselves, the world, and others through this activity. So let's take a look. This is one example of an activity, a piece of the activity that we do here. Latifah lost her father, mother, aunt, and godmother all before the age of 12 and was forced to live in with her abusive grandmother. As opposed to social relationships, and particularly intimate familial relationships, evoking a sense of pleasure, security, and safety for Latifah, the thought of being close to someone brings fear and anxiety. So she uses her best skills of avoidance and shuts out emotions to keep herself from being vulnerable to experiencing more pain and loss. As you can imagine, this has a profound impact on a key developmental task of adolescence, which involves building peer and even romantic relationships, which are necessary as you transition into adulthood. This, to me, fit very well in terms of understanding that kids who had experienced complex trauma often also end up in very violent relationships because they end up being suspicious or not trusting and maybe overprotective of the individual they're in a relationship with, or intrusive. And so understanding that that impact is a developmental impact and impacts all relationships becomes an important understanding for staff that are working with these youth. Next, oops, went too far. Go back. The third module is, as I said, focused on survival coping strategies and is devoted to understanding those coping strategies and then helping the participants to be able to come up with alternatives, not in isolation, but working with the youth to come up with some alternative coping strategies that would fit for that youth. So this is an example of some of the part of the activity that we would do. We have a young person now who's gone through an intervention, and a staff person who's gone through something like the Think Trauma Toolkit. And you'll see that the young person in this one is saying, now that Mr. Boat is here, I feel safe. When I get worked up, he don't put his hands on me, which makes me madder. He just tells me I'm safe, gives me a minute to breathe, and lets me go in and draw. He don't think I'm going to kill myself or someone else with my pencils like the rest of them. My pencil helps me draw and calm down. He gets me. So the idea being that if you can help staff to be able to understand individual youth and their needs, then you're more able to intervene appropriately in each of the situations. Another piece of this module, or the way that it ends, is that the participants, so all 6 at that table, will take the young person that they've been working with and develop a trauma-informed, individualized safety plan. So they'll use the information in terms of what the youth's traumas were. They will explore maybe what are some of the warning signs the youth might be becoming overwhelmed. What are some of the coping strategies that they're currently using, and then sit down with the youth and the rest of the team members and come up with some alternatives that the young person may be able to use. We really try to emphasize that when you're coming up with alternatives, these may not be strategies that the youth already knows how to do. So there are things that it's kind of a trial and error, and we ask the staff working with the youth to practice, to give opportunities in the moment to use those strategies, and some of them are thinking strategies or cognitive strategies that rely on them reframing a situation, and others of them may be more related to what I would refer to as sensory-based interventions. So we have a number that are listed, and we talk about the necessity of practice in those. The final module, as I had discussed before, is really focused on the staff. We talk about how hard it is to really hold the youth's trauma, the difficulties sometimes in working in organizations that care for others, like juvenile justice agencies or child welfare agencies, and being able to take care of oneself on top of that. We borrow some of the information from a book called Trauma Stewardship and a handbook based upon the trauma stewardship model, and find that it's been very helpful to help individuals assess where they are at the moment in terms of their own feelings and own experiences of working with these youth. One of the activities that we do in this last module is a reflection for them, kind of an assessment about where are you in terms of your thinking. And one of the pieces that's come from that is how this work can change your own view of yourself, your view of the world, and your view of others. So this statement is one that kind of captures that. It says, since I started this job, my wife has said that I have changed. She says that I have become cold-hearted. I know I have changed. It comes with the job. So we recognize that, our job should not significantly change the way in which we think or in which we interact with those that we love. But we know that that does happen, and the first step is kind of recognizing that. So we spend some time helping participants be able to recognize that modification or that shift in their thinking. And then, just like with the youth, we ask them to take a look at where they are in their lives and think about what might be some of the strategies that you could engage in terms of self-care. And I think about this is more than I'm going to go get a pedicure tomorrow. This involves really looking at lots of things. Do I need to advocate better for myself at work? Do I need to be able to set boundaries better in terms of my work with youth? Because a lot of times we take these kids home and they're with us all day, and we're focusing on them when we might need to be focusing on our own kids. And so we kind of give them permission, and we normalize that and give them an opportunity to think about what self-care options they need to put in place in their work environment, in their home environment, to help care for themselves. Okay. The toolkit that I just discussed is not yet available, but should be available in the next week or two. It is a free resource that you can access through the National Childhood Traumatic Stress Network, and this link will take you to our juvenile justice pages, which have lots of information, and it'll also be the page where this toolkit will be downloaded. You can download it, and it includes all of the facilitators' guides, and also some ways in which you can get assistance to be able to deliver the curriculum if it's something that you're interested in. So before I go on to the last segment, I guess I'll ask, are there any questions? And then Carly, I don't know if anyone has questions.
There is one question, but I'm actually going to hold it until the end.
Okay.
All right.
So Dr. Ford alluded to the intervention that we used in the Ohio Department of Youth Services, and I'm just going to kind of briefly go over that one. We were, back in 2006, looking at ways in which we would be able to reduce seclusion, reduce restraint, improve the quality of the milieu on our units, decrease the likelihood that our staff members would be hurt physically or emotionally. And so that led to us developing a committee that we called the Trauma Impact Reduction Program Steering Committee, after recognizing that many of these difficulties or the issues that we wanted to deal with had their root in dealing with with kids who had experienced complex trauma. We developed a number of different committees. We thought it was important to look at, what policies we need to change or review to make them more trauma-informed. we decided we needed to be able to develop a training for staff so that they could understand what they were looking at. And the training that was developed for staff is actually a precursor to the Think Trauma Toolkit, which I just presented. We also looked at screening and assessment using some of the tools that Dr. Ford talked about. We selected a treatment intervention, which was Target. And then we looked at how we were going to collect data, because if you're going to do something like this, it's important to know whether or not what you're investing in has an impact. And so we collected some data on points that were important to us. And finally, we focused on environments, because it was important to see how we can improve the places where our youth live and places where our staff were working. There we talk about the PTSD Reaction Index and the MASI, which were a part of our intervention. There's a nice picture of Julian and his lovely wife. That we selected Target as our intervention, and they came out and trained for us, all of the individuals who were going to be implementing Target, and also provided consultation. As I noted, we did some training with all of our staff, the early version of our Think Trauma Toolkit. And when we focused on environments, and the pictures here are ways in which we were able to create comfort rooms in our secure facilities, which were places for kids to practice the skills that we said were important. We place a big value on the fact that you can say something, but it means a whole lot more when you do something to help a young person practice. So no matter what intervention you select or what process or milieu intervention you think about, unless you're going to support that, it becomes pretty meaningless. So we gave a place where we thought that kids could practice skills with the support of staff. And as I said, there was a data committee that focused along with our Ohio Department of Mental Health. And so our pilot essentially was that we used all of those things I just discussed, environments, policy, training, target curriculum, on 3 of our mental health units. And then there were 2 mental health units where we essentially were doing treatment as usual, everything we normally did, but we didn't use Target. We didn't provide the additional training and support, the comfort rooms, to those individuals. And so we then tracked to see what happened. These were our goals, which I've discussed. And much like Dr. Ford had discussed, we had significant improvements in terms of use of safety interventions, treatment versus control. So far fewer safety interventions for our treatment group or our target group over our control group. This is our use of seclusion. Significantly better for the group that utilized the overall interventions. We also saw some reductions or decreased levels of youth threats on the unit. So to me, that's saying we've taught kids how to utilize other skills besides aggression, or to see situations differently so they weren't acting out on the units. We saw some improvements in terms of depression and hope and optimism. And finally, while we had some similar improvements in terms of both units having anxiety and PTSD improvements, the group that experienced Target and had all of the other interventions showed improvements over the other units. Okay. At the moment, we are part of a learning collaborative that utilizes both the Think Trauma Toolkit and the intervention I talked about earlier, trauma and grief components therapy for adolescents. That's across 5 states. And really looking at what happens when you pair those 2 things together. I was interested in whether or not this could be replicated in that sense, using some sort of an intervention along with training for staff. And we've found that many of our sites are realizing similar results in terms of reductions in incidents. Staff report that they work more effectively with the youth, and that the youth are voicing that they feel more understood and safer and feel like they can work with their staff better. So we're beginning to see some good outcomes of bringing together an intervention and training for staff. And that concludes my presentation.
Thank you so much, both Monique and Julian. That was wonderful. The one question that I wanted to hold to the end, which I I think it would be wonderful if you could both respond to is why the topic of trauma is very recently becoming an issue, or at least an issue that's being raised across multiple systems.
Well, Monique, while you're catching your breath, I'll jump right in. I think there are many reasons. It's a great question. You'd think that this would have been something that would have been recognized decades ago, and I think that there were many people in the juvenile justice system years or even decades ago who recognized that the kids who come into the systems often are very troubled, even though they act as though nothing's bothering them and as if nothing affects them in many cases. Once you get to know them even for a short time, it's very clear that they're deeply troubled, and they're also incredibly resilient. So I think that probably the reason why it's become much more of a concern is because in our whole culture, we're recognizing that trauma, violence, victimization has incredibly bad effects. We've learned that through large studies like the Adverse Childhood Experiences Study, the ACEs study, with thousands and thousands of adults in the Kaiser Permanente health promotion or health maintenance organization, where having experienced adversity, trauma in childhood leads to a great increase. It doesn't cause necessarily, but it really drastically increases the likelihood of not just mental health problems and behavioral problems and academic problems, but also literally very serious illness. It stresses, trauma stresses the entire body, and as a result it compromises the immune system, or at least it can stress it. It compromises relationships, and I think that that's the larger awareness that has led this to filter down into the juvenile justice system or up into it. But I also think that there are so many people in the justice systems with whom I've interacted, and I suspect people in the audience as well, who are so deeply concerned about kids that they've been looking for some way to work with these kids that isn't just trying to get them to straighten up and act right. And trauma, remarkably enough, as big a problem as it is, it opens the door to being able to actually help kids to regain control of their lives and their emotions and their behavior in a way where if you don't know how trauma affects the body, the brain, the mind, you're just basically trying to kind of push against a wall. Trauma actually opens a door to all kinds of potential ways of education and rehabilitation. So it's actually a great opportunity, even though it is a very tragic thing to know that so many kids have been so adversely affected. So that's my 2 cents.
And I would just briefly say I agree with what Dr. Ford indicated, and I think it's really nice to see it as it's a nice way. It's a nice lens through which to view many of the difficulties that young people experience. And so it's not that you don't also have a mental health condition or you don't also have a substance abuse issue, but at least for me, in juvenile justice, we selected working on trauma as a way. I mean, we were already on mental health units. We had lots of mental health interventions, but focusing on trauma really opened a door to help those other interventions work more effectively. So whether or not we were talking about, kids who experience psychosis, or if we were talking about even on other units, kids who were charged with sex offenses, for the first time we could really focus on their own issues and how it was that those things may contribute to or exacerbate what we were dealing with on the unit. So I think it's that for that reason I think it has been important that it's, whether it's this system, whether it's child welfare system, mental health system, everyone I think is beginning to see that by focusing on that and the very core issues of affect regulation, that you're able to have better outcomes with the other interventions and processes that you're using.
Thank you. We do have one other question regarding how well psychiatrists are typically trained with regard to trauma.
Well, neither one of us are psychiatrists, so we're a little speaking out of school, but some of my best friends are psychiatrists and some of my best colleagues, and I would say that some psychiatrists are incredibly knowledgeable about trauma, traumatic stress, complex trauma, and many, if not most, are not, but that's no different than any other profession that I know of: clinical psychology, social work, psychiatric nursing, counseling, marriage and family therapy. I think there's a growing interest and a growing body of experts in every field, but it's also an area where I think it's clear we can't count on somebody who is a very skillful and expert professional in any of the human service or mental health fields necessarily being expert about traumatic stress, or particularly about the impact of traumatic stress on adolescents, let alone specifically adolescents involved in juvenile justice. So they're definitely out there, and I think, and the psychiatrists I know who really have gotten the training and have done the hard work that we all have to do in order to become truly knowledgeable about trauma and adolescence and juvenile justice, they will still use the full repertoire of psychiatric, psychotropic medications. They will still use the full repertoire of psychiatric diagnoses, but they also tend to look much more specifically, rather than, like I said earlier, trying to treat many different disorders. They really try to focus their treatment and their diagnosis on the complications of stress reactivity and the kind of survivor syndrome that Monique and I have both been talking about. And I think as a result, they are taking some very innovative approaches to working with kids. It includes the traditional approaches to treating depression, anxiety, ADHD, hyperarousal, and inattention, but it also goes a little bit further. For example, I have a colleague here at the University of Connecticut who is just doing, I think, a very innovative study looking at the effects of a novel treatment for ADHD, guanfacine, which really reduces the kind of anxiety-based hypothalamic pituitary adrenal system arousal, and using that for kids who have serious problems with hyperarousal and trauma histories, and finding that actually can be a potentially very helpful way to help these kids to not so much get rid of the arousal, but to channel it and manage it. And I think that's where we're going in psychiatry and psychology together.
Thank you. At this time, we do not have any more questions, so I would like to thank you both very much, Dr. Ford and Dr. Moreau, for presenting today. It was very informative. We will be posting a recording of this webinar and copies of the slides on the Policy Academy Action Network resource webpage. The link to that webpage was provided to the core team members from each state participating in the Sampson MacArthur Initiative. If you have any questions, you can always contact one of us following the presentation. Once again, thank you very much.
Thank you, Carly.
Thank you. Bye-bye.
Bye-bye.
Bye.